Assalamu alaikum. I am Professor Alaa Wafa, Professor of Diabetes and Endocrinology. I am your chief tutor. That's a lecture related to thyroid disorder that give you a medical aspects of thyroid disorder. Here, the anatomy of thyroid gland, as you know from your background, that is the site of detection of thyroid gland. That's right loop, left loop isthmus, and beneath that the parathyroid gland with the recurrent laryngeal nerve and trachea underlying these glands. And as you see here, the histological pattern of thyroid gland, the functional unit of thyroid gland here, the follicle. And follicle, this is the sites where key thyroid element function are present. This key is thyroglobulin with tyrosine and that iodinated by presence of the iodine that give lastly to two main hormone, thyroxine, that's T4, and triiodotyrosine T3. Here the thyroid give and produce two metabolic hormone, two principal hormones secreted by thyroid, either thyroxine, tetraiodothyronine T4, and triiodothyronine T3, required for homeostasis for all cells and influence cell differentiation, growth, and metabolism. Consider the major metabolic hormones because they target virtually every tissue. Thyroid stimulating hormone, TSH, regulate thyroid hormone, likely production, secretion, growth, and is regulated by the negative feedback action of T4 and T3. يبقى here TSH secrete from the anterior pituitary gland with the regulation of the thyroid hormone, either hypersecretion and under influence of the level of T3, T4 in the blood. This diagram shows the relation between hypothalamus, pituitary, thyroid axis. So the hypothalamus, pituitary, thyroid axis for negative feedback. As you know, hypothalamus makes secretion of TSH, of TRH stimulation, thyrotropin releasing hormone that stimulate anterior pituitary gland to give TSH, that stimulate thyroid hormone to give T3, T4 that actively present in the blood in the free and bound form that go to the target organ. Production of T3, T4, and T3. T4 is the primary secretory product of thyroid gland, which is the only source of T4. The thyroid secretes approximately 70 to 90 microgram of T4 per day only. T3 that derived from two processes. The total daily production rate of T4 is about 15 to 30 microgram, and about 8% of circulating T3 comes from deiodination of T4 in the peripheral tissue. About 20% come from direct thyroidal secretion. So, transformation from T4 to T3, 80%, 20 only from thyroid itself. T4, that's a prohormone for thyroid gland, that's for T3, that's a prohormone. T4 is the biologically inactive in the target tissue until converted to T3. So activation occurs with the 5-iodination of the outer ring of T4. T3 then becomes the biologically active hormone responsible for the majority of thyroid hormone effects. Thyroid hormone stimulates metabolic activity in the most tissue. Thyroid hormone, especially T3, regulates rate of overall body metabolism. T3 increase BMR, basal metabolic rate. Calorigenic effect. T3 increase oxygen consumption by most peripheral tissue, increase body heat production. Another metabolic effects of T3 that stimulate lipolysis and the release of the free fatty acids and the glycerol. Increase expression of the lipogenic enzymes. Affects cholesterol metabolism and stimulate metabolism of cholesterol to bile acids. Facilitate rapid removal of the LDL from plasma. Generally stimulates all aspects of the carbohydrate metabolism and the pathway for protein degradation. Additional added values and benefits of the triiodothyronine on T3 that initiate or sustain differentiation and growth. That's very important. Stimulate formation of the protein, which exert trophic effect on tissues. Essential for neural development and maturation and function of the CNS. Important for normal reproduction. And T3 is considered the major regulators of the mitochondrial activity. So here the background thyroid hormone, from where anatomical site, histological pattern of the follicle, and the relation between T3 T4, and after that, that is biological function of T3. So what about disorder of thyroid gland? The thyroid dysfunction here carry two main changes, either hyposecretion and hypersecretion, hypothyroidism and hyperthyroidism. That's typical hormonal level in thyroid disease. With hypothyroidism, all of you know that with hypofunction thyroid gland, so there is low levels of T3, T4 and negatively high level of TSH. With the hyperthyroidism, there is a very high level of T3, T4 and low level of TSH. Prevalence thyroid function. That's usually thyroid stimulating hormone level as a measure of thyroid function. This is screening test. The only screening test for thyroid function is TSH. And prevalence of elevated TSH level in hypothyroidism was 9.5%, and the prevalence of decreased TSH levels in hyperthyroidism was 2.2%. Lipid levels was present and increased in thyroid function declined. 40% of patients taking thyroid medication have abnormal TSH levels, and that is additional laboratory test for thyroid function. So her serum T4, and that's normal level, and free T3, free T4, and added to this thyroid auto antibodies, thyroglobulin antibody, TGEB, and thyroid peroxidase antibody. That's very important. So when you ask for TSH as a screening, and then ask for free hormones rather than total hormone, and you should ask for thyroid autoantibodies to declare that your patient with hypothyroidism have autoimmunity or not. So whom to screen? That's very important question. Home to screen, screening for disorder of thyroid function. Screen men every 5 years beginning at 35 years of age. Women every 5 years beginning at 35 years of age. Pregnant women as soon as possible after conception up to 3 months after giving birth. And patient more than 60 years of age once a year. I need to add some important data regarding special population to be screened for thyroid disorders. Added to this, patient with this lipidemia, abnormal lipid profile, any cardiac patient with arrhythmias like atrial fibrillation, any unexplained obesity, patient with menstrual disturbances, females with abnormal menstruation, patient with depression. We have a different categories of her of patient likely to should ask for thyroid hormone like TSH to screen for thyroid problem, likely to avoid any misdiagnosis or other diagnosis in these diseases after that. And this slide, I think, is a very important in your study. That's disorder of thyroid gland. So you have different aspects of the thyroid. From function, either you have a change in the hormone, hyperfunctioning hormone, and the hypofunctioning hormone. From anatomy of the gland itself, if the gland itself enlarged by diffuse enlargement, or nodular enlargement, or single nodule, or there is no gland, it's aplasia or hypoplasia, and so on. So third aspect here is the underlying cause. It is inflammatory or immune or infection. So you must think with thyroid in different three main aspects: as a function, as an anatomy, as the underlying cause, immunity and inflammation. We need her to discuss with you hypothyroidism. In a patient with hypothyroidism, we can define it as the disorders with multiple causes in which the thyroid fails to secrete an adequate amount of thyroid hormone. The most common thyroid disorders, and usually caused by primary thyroid gland failure, also may result from diminished stimulation of thyroid by itself. So the gland itself may be a primary failure or second failure. So that is all symptoms and signs related to thyroid disorder. That's clinical feature of hypothyroidism. Sometimes there is a tiredness and fatigue. Sometimes forgetfulness and slow thinking, moodiness, irritability, depression, inability to concentrate, thinking, abnormal thinking with the slow thinking, slow celebration, and thinning of the hair and hair loss, loss of body hair, dry, patchy skin, weight gain, cold intolerance, elevated cholesterol, and family history of thyroid disease or family history of diabetes, buffness of the eye, enlarged thyroid gland likely to be in goiter, hoarseness of voice or deepening of voice, persistent dry or sore throat, difficulty swallowing, slower heartbeat, menstrual irregularities, heavy period, infertility, constipation, muscle weakness, and cramp. It's not mandatory to find all these symptoms and signs in one patient. Sometimes your patient have 1 to 2 or 3 symptoms and without other symptoms. Here are the examples of like you see the patient that's intolerance to cold, expressionless face, bloated, loss of the outer third of the eyebrow, thickened tongue, dry skin, cold, yellow, easy fatigability, weight gain. With the cardiovascular background, there is sinus bradycardia, and with increased incidence of atherosclerosis, with a slow celebration and depression. Sometimes mucinous infiltration of the special areas like tongue, giving slurred speech. Vocal cords, hoarseness of voice. Carpal tunnel syndrome. That is examples in cretin child, her, another. That's hypothyroid face, puffy lips, thick lips, and mask face. Another one. All these are examples. That's classic myxedema or hypothyroidism. That's myxedema face. That's classic. And another, this gentleman with the different stages in his life, with different changes in the face expression. The very important point in our clinical practice to make differentiation between hypothyroidism and depression. So we have many features overlaying between both. That's depression and that's hypothyroidism. So in hypothyroidism, there is bradycardia, cardiac and lipid abnormalities, cold intolerance, delayed reflexes, goiter, hair and skin changes. And in depression, sleep decrease and suicidal attempt and weight loss and appropriate increase with the appetite and sometimes decrease. With the in between both is the depression and the hypothyroidism, there is constipation, appetite decrease, constipation, and decreased libido and delusions, depression, mood, diminished interest, sleep increases, weight increase, fatigue. That's in between. So here you should differentiate all times between both, and you should eliminate. Population at risk of hypothyroidism: women, prior history of Graves' disease or postpartum thyroid dysfunction, likely to be postpartum thyroiditis; elderly population; other autoimmune diseases likely to be rheumatoid arthritis, Sjogren syndrome, and systemic lupus erythematosus, and family history of thyroid disease, pernicious anemia, type 1 diabetes mellitus. Hypothyroidism types. Her hypothyroidism may be primary, may be secondary, may be central. So primary, that's from thyroid destruction; central or secondary hypothyroidism from deficient TSH secretion, generally due to cellular lesions such as pituitary tumor or craniopharyngioma that make pressure hard, and destruction of the normal viable pituitary tissue, and frequently the congenital. Central or tertiary cause from deficient TSH stimulation above the level of pituitary, lesion from pituitary stalk, or hypothyroidism. It's much less common than secondary hypothyroidism. Here, primary hypothyroidism can be caused by some underlying different causes like congenital hypothyroidism, agenesis, and that lead to defective thyroid hormone biotensis due to enzymatic defect. Sometimes tissue destruction itself. Thyroid tissue destructed from thyroiditis, other autoimmune, some autoimmune diseases like chronic autoimmune thyroiditis, like Hashimoto and other types of thyroiditis. Radiation, usually radioactive iodine treatment for thyrotoxicosis, sometimes removed by surgery, thyroidectomy, and other infiltrative disease of thyroid like hemochromatosis. Some drugs can lead to destruction of thyroid gland, like lithium that enter in some constituent of the antipsychotic treatment, iodine and iodine-containing drugs, radiographic contrast agent, and interferon alpha. So here, the etiology here may be congenital and maybe thyroid destruction. So when you treat any hypothyroid patient, please ask yourself, don't start treatment without reaching the cause. So ask yourself, what is the cause of this hypothyroidism? You will start replacement therapy as soon, but you must search for etiology of hypothyroidism as you treat. You replace hormone for patient, yes, but you treat the disease, not replace hormone only. So what about thyroiditis? Chronic thyroiditis here likely cause one common type of thyroiditis, Hashimoto thyroiditis. Occurs when there is a severe defect in thyroid hormone synthesis, is a chronic inflammatory autoimmune disease characterized by destruction of thyroid gland by autoantibodies, anti-thyroglobulin antibody, and the anti-thyroid peroxidase, and other tissue component. Patient present with hypothyroidism, painless goiter, and other overt signs. Person with autoimmune thyroid disease may have other concomitant autoimmunity like rheumatoid arthritis, systemic lupus, Sjogren syndrome, sometimes associated with type 1. So annually, with type 1 diabetic patient, please ask for TSH for fear of concomitant hypothyroidism. Will often have significantly elevated anti-TPO, anti-thyroid peroxidase titch. What about another types of hypothyroidism that associate with the vague symptom or sometimes no symptom that called subclinical hypothyroidism? And this type of hypothyroidism is subclinically present, defined as an isolated elevation of TSH in the setting of normal T3, T4 levels. Symptoms may be present or absent. So that is presented by this diagram. That's progression of thyroid disease that differ from different stage between euthyroid, subclinical hypothyroidism, and overt hypothyroidism. In euthyroid state, there is normal T3, T4 TSH. With the subclinical hypothyroidism, there is some elevation of TSH with normal T3 and T4. With overt one, as you see here, there is low level of T3, T4 and high level of TSH. Subclinical hypothyroidism may be confused with other disorders. Sometimes patients with the subclinical disorders have a hyperlipidemia, depression, and some gynecological conditions like abnormal heavy menstruation and aging. What is the relation between subclinical hypothyroidism and the cardiovascular disease? Cardiac manifestation like left ventricular systolic dysfunction and the diastolic dysfunction. Increased systolic time interval, myocardial infarction. Coronary artery disease have some changes like patient with underlying subclinical hypothyroidism with coronary artery have elevated total cholesterol level and elevated LDL level and triglyceride with associated aortic atherosclerosis and hyperhomocystinemia. Subclinical hypothyroidism increases risk of myocardial infarction and contribute to 60% of MI cases in patients with diagnosed as subclinical hypothyroidism. Subclinical hypothyroidism contributed to 14% of all MI incidence in the study population. Subclinical hypothyroid and independently associated with MI. And the question here, if there is no symptoms and signs of subclinical hypothyroidism, so our job here to treat or not treat. There is two ways, either to wait and see or to treat. But here, there is a rationale for treating subclinical hypothyroidism with some potential benefits from treatment. The early treatment here prevent progression to overt hypothyroidism. Added benefit, early treatment improves serum lipids, which may reduce risk of death from cardiovascular causes. Third important one, reduced symptoms include psychiatric and cognitive abnormalities. And her treatment of the subclinical. What about treatment of hypothyroidism at all? Your patient with hypothyroid function with some hypothyroid symptoms that make change in quality of life. So treatment here called replacement therapy, HRT, hormone replacement therapy. And the goal of hypothyroidism therapy is to replace thyroxine to mimic normal and physiological level and alleviate signs and symptoms and biochemical abnormalities. Therapy initiation and titration. Therapy here with levothyroxine sodium, L4. Require individualization and patient dosing. So careful titration, very important. And the clinical evaluation important. And the laboratory monitoring with TSH is very important. Also, individualization of patient dosing influenced by age and weight. Cardiovascular deaths, severity and the duration of hypothyroidism, and the concomitant disease status. So there is a many individual variation between person and person during hormone replacement therapy. Levothyroxine sodium in the treatment of choice for the routine management of hypothyroidism. In adults, you start treatment 1.7 microgram per kg for body weight. In children, up to 4 microgram per kg of body weight. Elderly, less than 1 microgram per body weight. Clinical and biochemical evaluation every 6 to 8 weeks, 2 months interval until serum TSH concentration is normalized. Give the narrow and the precise treatment range for the levothyroxine therapy. It is preferable to maintain the patient on the same brand through treatment. Another way to make her this algorithm, how can you follow your patient? Initial levothyroxine therapy, when you start today your patient with replacement therapy, give him very low dose, and after 6 to 8 weeks, ask for TSH. TSH less than 0.5 micro international unit, so decrease levothyroxine dose by 12.5 to 25 microgram per day, or repeat TSH test. If it's between 0.5 up to 2, symptoms resolved, continue same dose, and measure TSH every 6 months, then annually or when symptomatic. That's simple way. And when TSH more than 3, increase levothyroxine dose by 12.5 up to 25 microgram per day. Thyroxine monitoring, very important to make monitoring, evaluation of the clinical response, assessment of patient compliance, and the assessment of the interaction of the applicable and the adjustment of those as needed. Clinical and the laboratory evaluation should be performed, as I said now, every 6 to 8 weeks interval while titrating. Every 6 to 12 months once euthyroid state is established. Caution in patient with underlying with cardiac disease, very important here. Very, very important to take some precautions when you treat cardiac patient with the levothyroxine therapy. Use L4 in those with ischemic heart disease, increases the risk of MI. As you know, we have here increasing cardiac overwork and the aggravation of the angina or cardiac arrhythmia. For a patient less than 50 years of age with underlying cardiac disease, initiate levothyroxine at 25 to 50 microgram per day with gradual increment every 6 to 8 weeks. For elderly with a cardiac disease, start L4 at 12.5 up to 25 microgram per day with the gradual doses increment at 6 week interval, and the levothyroxine 4 dose generally adjusted in 12.5 up to 25 micrograms. So the rationale here to start very low and go slow. Again, start very, very low and go slow for fear of precipitation of heart attack. What about pregnant lady or impact of maternal hypothyroidism on subsequent neuropsychological development of offspring? Undiagnosed hypothyroidism in pregnant women may make adverse effect on the fetus. Treating maternal hypothyroidism during pregnancy appear to be beneficial even when treatment failed short euthyroid state. Screening for hypothyroidism before or very early in pregnancy may be warranted. And treating hypothyroidism in conception, in pre-conception period and during pregnancy, that's very important. That's encourage adherence with levothyroxine replacement. Therefore, before conception, 3 months minimum. Monitor TSH before conception and during first trimester. Also monitor level of TSH level every 6 weeks throughout pregnancy. We should remember that during first trimester and euthyroid pregnancy, TSH will normally fail slightly. So a goal of TSH 0.1, 0.5 at a low level is acceptable. But very, very important clinical tips for you. The follow-up of your patient during pregnancy by 3 to 4 and 3 to 3 to confirm appropriate euthyroid rather than TSH itself. Called TSH have some changes during pregnancy, so the accurate to make follow-up with 3 to 4 and 3 to 3 rather than TSH. And I think this slide is a very important one that give you a chance to understand we have many factors that may reduce levothyroxine effectiveness. And so if a patient have malabsorption syndrome or reduced absorption or drug that increase clearance, a factor that reduce T4 to clearance, to T3 clearance, or some other drugs, all these drugs in this diagram and all these conditions affect the action of levothyroxine. So be cautious when you start prescribing replacement therapy for thyroid gland to alleviate these factors and deal with well. What about iron replacement? The majority of female have iron deficiency anemia, so using iron make increased TSH due to drug-drug interaction between iron and levothyroxine therapy. The last question, is there any role for T3 supplementation in the management of hypothyroidism? The replacement here by the levothyroxine therapy or T4? What about TSH? There is no role for TSH, for T3 in replacement. As documented by American Association of Clinical Endocrinologists, dedicated thyroid hormone combination of thyroid hormone or triiodothyronine shouldn't be used in the replacement therapy, and this is some photos show that the effect of treatment before and after during manifestation of hypothyroidism and after ingestion of treatment with very few years. As you see, there is a marvelous change. Thank you very much.